Should be all right. Good afternoon, everyone. My name's Steve Hodgson from the British Society for Surgery of the Hand. This is part 2 of our webinar series with the West African College of Surgeons. Topics, the very interesting one is soft tissue cover of the hand, which follows on nicely from the previous one on hand fractures. I get the impression West African surgeons see an awful lot more open fractures than in the UK, so I hope it will be a real benefit. We're very privileged to kick off with 2 of the great and good from British Society for Surgery of the Hand. So if I can introduce David Warwick, our current president, just to say a few words. Thank you, David.
Well, thank you very much, Steve. Thank you, everybody that's listening in. It's a real honour to be here with you all today. Earlier this year, back in February, Steve Hodgson, myself, and Anuj, who you can see as well, we went over to Abuja, and we were hosted by Falake, who's here today, and others, and we were very, very well looked after. And we had the most inspirational time, and we came back absolutely resolved to make something happen between the British Society for Surgery of the Hand and the West African College of Surgeons. And we had the experience of meeting so many of the West African College members, and we had food with them, we had drinks with them, and we had discussion and fun. We had a few lectures as well. And since we've come back, things have moved on. The BSSH has signed a memorandum of understanding with the West African College of Surgeons. And in principle, what we would love to see is over the next few years developing an educational program, and today's is just an example of that, but make that more and more formal if possible. The British Society for Surgery of the Hand is more than happy to be, if you like, a host hand society for the West African College. So people in the West African College can actually feel the BSSH for the time being is a resource for them to learn and to share and to be part of. But in due course, wouldn't it be fantastic if we can actually set up the West African Society for Surgery of the Hand? And anything the BSSH can do to facilitate that will be an absolute honour and a pleasure. Jonathan Jones, you can see here, he's the current chairman of our overseas committee. And Jonathan, I know, is committed to, over time, making this wonderful liaison continue. So I won't go on for any longer, but I really appreciate the lecture series, and we're all proud that between us, we can all develop this sort of initiative and learn together. So thank you all. I hope you all enjoy it, and I hope we all get to meet in real life sometime soon. Please all take care. God bless.
Thank you, David. So next we've got Jonathan, who David has already introduced. Jonathan leads on all the British Society for Surgery of the Hand's overseas projects, coordinates it, and he's had a very interesting last 12 months moving us into the virtual world. But he will say a few words about our plans for the future. Jonathan.
Thanks very much, Steve, and thanks, David, as well. And just a few slides, really, just to show what the BSH Overseas group do. So I'll see if I can screen share. I wouldn't say I'm a leader in virtual technology, but I'll do my best. No. Can you see this? Can you see my slides? Oh, no. Sorry, Steve, can you see the slides there or not?
No.
Okay, I'll come back to you. I think perhaps I'll try and, but you've still got connection. You can still hear me. Okay, just try once again. Okay. I think perhaps, Steve, what I'll do is I'll just do speak from my text if that's okay, but I'll try and go through. Can you hear me all right?
Yes, clear.
Unless you wanted to introduce the panel first, and then I can just get the slides up whilst you're introducing the panel. Would that be okay?
Okay, yeah, we can do that. We've got a good panel today. We've got Anuj Mishra, who's a plastic surgeon in Manchester. Works very close to me. He's had a big interest in overseas work, which he will tell you about, but I particularly picked him because he's a great teacher. We then got Sarah Mee, who is a UK hand therapist, probably the country's most experienced in working in Africa, and again a very famous educator in the UK and beyond. And then probably most important of all, we've got Jacob Legbo, who we met when we came to Nigeria. Jacob will be a real opportunity for us to learn about the West African approach to soft tissue cover of the hand. And then the second part after those formal presentations will be a case-based discussion where we reinforce the learning points by discussing West African cases. That will be led by Falaki, who again hosted us very well in Abuja. So, Jonathan, are you good to go?
Yeah, I'm really hoping so. It was the Dropbox seems to be really mucking around with me, but I'll just give that a go now. So I think I'll just use my words and really, I mean, the point really is that I wanted to say a few words about what the projects that the BSSH are involved with. I work in a shiny hospital in Peterborough in the UK. I'm an orthopaedic surgeon, and I'm very fortunate to have all the resources that we have with CT scans and MRI scans and so forth. But I appreciate that there are others who are less fortunate and in challenging areas of the world. Hands are vital for daily function and for life and the treatment of our hands, injuries, burns, and so forth. They've got to be treated well and in a timely fashion. So the BSSH really is committed to helping low to middle income countries in education and training of surgeons, but also other professionals, clinical officers and therapists. So one of our partner surgeons in Malawi said that really, if we can help to treat the working hands of a nation, then the nation can build, and that was very, very relevant for Malawi. So our projects basically are 10. Well, we have 10 projects as set out in our strategy about 3 or 4 years ago. We now have 10 partner projects in Africa and Asia, so including Uganda, Malawi, Sudan, Ethiopia, Myanmar. Nigeria comes really with the WACS Association, which has already been mentioned. But we partner with BFirst as well, so it covers Cambodia and Vietnam. And also there's a project in Nepal. So there are 10 ongoing projects. And sorry, I can't show you the pretty maps that go with this, but the BSSH really is focused on the goal of developing partnerships and doing this teaching and training around the world. And some of the organizations that we've been involved with are so Research Africa, the AO Alliance, obviously WACS that we've been talking about, but also with BART, the British Hand Therapist Society. You'll hear more about them, and also BFirst, which is the plastics organization. Research Africa, in fact, combined with the BSSH on the first project in Sierra Leone back in 2010. And that's an ongoing project with still lots of work to do. The current, coming to the end really, but the current pandemic has enabled a lot of virtual teaching, and there's almost too much of the Zoom going on. But our visits have stopped, and in place we have the virtual training. But it's helped us to connect more, I think, and I think it's quite exciting. Some of you may have seen the COVID-19 hand trauma webinar a few months ago, and then more recently the congenital hand symposium with BFirst, and also some burns ones. And there's more plans, but we need to get better at doing these. And I apologise for my poor screen share. Finally, the BSSH is a very large surgical society, and it's a charity. It's a non-for-profit organisation, and it's absolutely not about marketing and branding. The BSSH is not about BSSH. It's about you, the delegates, and that's including all of us because we're all delegates, individual surgeons, individual trainees, the therapists, clinical officers. And it's equipping you to do your work and to care for your patients. The emphasis is on partnership, facilitation, and mentorship, and so that your patients benefit. So that's really the nubbins of it. And my thanks really to you all for joining us today. And to the organisational committee for their work, and I do hope that it's a profitable and enjoyable educational experience, and that you find it helpful. So thanks very much, Steve. And sorry about the slides.
Thank you, Jonathan. And that set the tone, I think, and given us a real feel for what we're trying to achieve together. So I'd now like to introduce Anuj. Whilst he gets his slides ready, I can say a few more words about Anuj. He is a hand surgeon in Manchester, from a plastic surgical background. He's been active in British Society for Surgery of the Hand, and has really led a lot of the hand surgery educational work in Greater Manchester, putting on very successful trainee days and been a key figure in the Northwest Surgical Hand Society. So thank you, Anuj, for agreeing to share your knowledge.
Thank you, Steve, David and Jonathan. It's a real honor and pleasure to join this webinar. I'll kick off with the soft tissue cover of the hand wounds. It's a lot of topic to cover. The aim, as it was for the last lecture, was to discuss cases and learn from each other. We had, as David said, we had a very good visit to Abuja in February for the workshop, as well as the team trip to Sierra Leone with Steve. Really enjoyed both these trips, and we learned so much from each other. And the aim is to have a happy team, and that applies to all our the hand service. It's a big team, and we work together, the doctors, nurses, and the therapist, as a part of the multidisciplinary team to give the best service to the patients which they deserve. The indications for the soft tissue cover of hand wounds are quite similar across both continents. They differ in the proportion and the severity of these indications. The main indications are mainly trauma, infection, and burn contractures, and sometimes following burn contracture release, congenital hand conditions, and skin cancers. As you can see from our experience from Sierra Leone and Abuja, the indications are similar, but the proportion of cases of burn contractures, trauma, infections, chronic and acute osteomyelitis, as well as congenital hand and burn contractures, have a different cohort of patients in these cases. So the aim is to, for any soft tissue defect, is to identify what exactly is lost, what are the options available, and to discuss the choices with the patient and come up with the best selection for that patient within the limited resources which we have, based on which region we are working. The overall aim is to provide a minimal stable hand function. And as far as any limb reconstruction is concerned, we always aim for proximal to distal. If we're talking about burn reconstruction, proximal to distal reconstruction, so that we can put the hand out in space and always start with the winner, not start with something which is complex, like a post-burn swan neck deformity or a boutonniere deformity correction. And that will not lead to as good results in the patient. So for trauma, we follow the general ATLS principles to debride the wound, after ATLS principles to debride the wound, stabilize, aim for functional reconstruction, and to control the infection, and plan the rehabilitation as soon as we start the treatment. The rehabilitation should not be left at the end. And that's what we aim, wherever we go, we aim for rehab as soon as we start our management, surgical management of these cases. As in this case, I'll just show a lot of cases today and discuss them later on in the Q&A section as well. This is a rollerblade injury. So the aim is almost like a pseudotumor excision. So debride the wound and stabilize it, and then identify how big is the defect. In plastic surgery, we say we use what we call as reconstructive ladder, start from the basic principles of allowing the wound to heal by secondary intention, or what we call as WACS therapy now. Sometimes we use a WACS therapy now. But using skin grafts, split thickness, full thickness skin graft, and local flaps, regional flaps, and distant flaps. And sometimes we go straight on what we call as a reconstructive escalator. And if it's a complex defect, go on and use a free flap option as well. But we have to be mindful of what resources are available to provide those. And we can always go up and down the ladder to choose the best option for the patient. Going back in the history is very important. It's important how the First World War and Second World War gave birth to the modern plastic surgery. So it's important to know the history. We always say those who don't remember the past are condemned to repeat the mistakes of the past. And these have been the workhorses. The pedicle flaps have been the workhorses for hand defects. Mainly the radial forearm flaps, and more later in 1980s, late 80s, the posterior interosseous artery flaps. It all started with what we call as a random pattern flap, which means it doesn't have a well-defined blood supply. What is a flap? For trainees in the audience, flap is a piece of tissue which has its own blood supply, whereas graft doesn't have its own blood supply and relies on the blood supply of the recipient bed. If the blood supply is not known, we call it random pattern. So we raise it as a 1:1 pattern, and it will survive. If you want to raise a longer pedicle, we need to make sure that there's a well-defined blood supply in that. In that, what we call as an axial pattern blood supply. In this case, very commonly used is a groin flap. We use a lot of groin flaps, and I saw quite a few groin flaps in Abuja as well. It's based on the superficial circumflex iliac artery, and it's a large flap. And sometimes we still use this flap in UK as well. For example, if you're planning a complex reconstruction in a complex hand defects, and if you're planning to do a toe transfer later on in that patient, this provides enough soft tissue to that area, and then we can do a toe transfer, so we don't compromise on a blood supply if you're planning a toe transfer later on in these cases. So we have moved, as you can see, in the last 60 years, we've moved from random pattern flaps to complex free flaps for composite reconstruction. Adipofacial turnover flaps also have been used in this slow history of the growth of flaps. It's a very good flap if you're not sure about the blood supply. Again, these can be random pattern or axial pattern. I'll show you some cases in burn reconstruction. Also in finger defects, you can do adipofacial turnover flaps to get a good blood supply in this region. Again, if you're traveling and if you're working in a peripheral unit, adipofacial turnover flaps can provide a good substitute to complex reconstructions. So we have different choices. As you can see, we can have a random pattern flaps, axial pattern flaps, and free flaps, and it's based on where you're working, what kind of defect it is, and how soon you want to rehabilitate the patient. Very important. So we always say we rob Peter to pay Paul, and be aware of that if you're creating a defect, if you're buying something, taking something from elsewhere, try to hide the donor site and minimize the donor site morbidity as much as possible. Always ask the patient how the defect will look, and show them, if they have pictures, show them where the defect, the donor site morbidity will be like. Do not assume that patients will accept that donor site morbidity. Sometimes we try to hide the donor site as much as possible. So it's very important to be aware of how the split thickness scars, especially in dark skin people, it's very important how the hypertrophic scars and the keloidal scars can become a big nuisance if you don't hide the donor site morbidity or don't minimize the donor site morbidity. If you're planning flaps, especially perforated flaps and free flaps, it's important to use the modern technology. It keeps changing every decade, but be mindful of going on to the courses, be aware of the recent journals and changes. It's important to keep pace with the new technology. Every 5-10 years, there'll be another flap, but it's important to keep a workhorse of at least three flaps in your armamentarium to use in complex reconstruction. And then you can modify them subsequently. it's important to, I'll discuss a few papers. Pontin is being popularized mainly for lower limb flaps as called super flaps because the first time they used in the ratio of 3:1 and taking the fascia with it. It's called fasciocutaneous flaps. Cormack and Lambati has popularized in their books of these flaps for both, they describe all the flaps based on the blood supply into A, B, and C and D. And most of the flaps which I've mentioned earlier are either type C and type D flaps, which we use for hand reconstructions. As you can see, these are proximally based flaps around the elbow. All joints, like all orifices, have got very good blood supply around them. So we can make a lot of flaps around that region. We can make a lot of flaps around that region as well. So, this is around the elbow, but we can use those as free flaps later on as well. This is the ulnar recurrent vessels. We call it superior ulnar collateral vessels, which is based on that area, which is the same as when we're dissecting the high cubital tunnel or doing ulnar nerve transfers. That's the area which we dissect. It's been described in 1500s by Tagliacozzi. They use it for nasal reconstruction, and we come back to that as an antefacial flaps for elbow defects, just to show you that some of the elbow defects in these cases. Going back to the pedicle flaps, the workhorse has been the radial forearm, both as a free flap, which was described for head and neck reconstruction, but later on used in the hand reconstruction, both reverse flow. Very important to test the LN test both preoperatively as well as intraoperatively as well. So before you divide it, always check it by putting a bulldog clamp around these vessels so that we don't, to avoid the 10–15% chances when the radial and ulnar artery don't communicate with each other distally in the palm. This is just to show you how the radial forearm flaps is raised and its different combinations. We can use the palmaris longus with it if we need to do a tendon reconstruction along with it. A lot of times I'll show you some of the cases where we can use silicone rods and do the simultaneous reconstructions. But most of the times, if there's a complex defect, we can do a soft tissue cover first and then come back and do the tendon reconstruction at a later stage. This is just to show you some examples of radial forearm free flaps, pedicle flaps for reconstruction. Initially, the flaps used to be very thin. Now we have modified it to make it a suprafascial dissection for most of it to decrease the thickness of the flap. Or if you're doing it as a fasciocutaneous flap, you can come back and do the fascial reconstruction. A lot of times we don't like to tunnel because everything swells. So it's important sometimes to just open the whole defect and then come back and do the Z-plasties at a later stage if there's a contracture. Just to show how it looks, this has been thinned out. Zencoli popularized this flap. Again, I'll say done quite a lot of posterior anterosseous flaps, but it's not a flap for the beginners. So always start with the flap which works very well. So radial forearm works very well, but it's a dominant artery. Posterior anterosseous artery is not a dominant artery, but you will find some cases, the more posterior anterosseous flaps you'll do, you will always find 1 or 2 cases where you will get stuck. It's important to be aware of the anatomical variations. So important to note where the posterior anterosseous artery lies between the 4th and 6th compartment in the initial part and the 5th and 6th compartment in the distal part. How do we raise it? And people have described, Rajesh Saupati has described taking a small tail in the distal part to decrease the venous congestion in these cases. And people have described opening the whole area to prevent any swelling in the flap and the flap dying from congestion as well. Posterior anterosseous usually is very good for the first web space as well as reaches up to the MCP joint. Very difficult to extend it distal to the MCP joint. If you have to raise it distal to that, you need to use a different flap. Always what we say is planning in reverse is important as well. Again, just to show you how the people have described the variations and the dissections. One of the technique is to identify, give incision in the proximal part and identify the vessel. If the vessel is not there, you can still bail out and convert into a Becker flap, which is the ulnar artery perforator flap, or delay the flap rather than just losing the flap at that case. And these are small cases when you're starting to do these flaps. It's important to take precautions in these cases. It's important to identify the posterior anterosseous nerve which runs close by, so that there's no morbidity of the posterior anterosseous nerve in these cases, especially in the proximal part. Distal part, it doesn't matter, it has already supplied its motor supply. And we always harvest the posterior anterosseous nerve for other cases as well. to show you some of the cases where how far it reaches. It can reach very slightly just distal to the MCP joint, but it doesn't go beyond that. Sometimes by taking it slightly more proximally, you can do an extended PIA flaps as well. Showing some of the cases again, you can combine it with complex reconstructions. If you've done a metal work, you want to cover the metal work at the same time. So it's very, very important to do the planning at the same stage. Like I'm showing you this case just to highlight that sometimes you can get stuck if, as you can say in this case, by opening it, there was no perforator was found, so it was converted into a Becker flap. And that's, again, you can keep it you can do it as a perforator flap, or if you think the blood supply is not very good, you can just do it as a pedicle flap. And yes, it does look bulky initially, but later on you can always trim it. So as you can see, it does look bulky, but and you just make sure that you cover the skin graft and come back and defat the flap at a later stage. The key is to make sure that the flap, the part which you want to cover is covered and the flap is not lost. And that's the only criticism of pedicle flap. Sometimes if you don't plan in reverse properly, sometimes we can lose on that part. We can do it as a lot of complex reconstructions. We call it perforator flaps, mark the perforator at the same time, do it as, and that's where the orthopedic and the plastic surgeons work together so that you can help at the time of the external fixator and skeletal stabilization, mark the perforators beforehand so that they are not damaged in the time of application of external fixators, and can do it as a hatchet flap or a perforator flap or completely islanded flaps. Whichever variation you want to do, you can do these flaps. In these cases, it's important to be aware of the geometry of flaps when you're raising either a random pattern or a pedicle flaps. Coming to the finger flaps, again, I'll mention a few things for trainees in the audience. The Atasoya flap, which is the VY flap on the flexor aspect. It's important to identify how the defects are. So if the LN classification is for the defects on the fingers. So if there's a transverse defect, we can just do it like a VY advancement flaps from the volar aspect. If it's a volar oblique flaps, you need a cross finger flap. If it's a lateral oblique flap, you can do what we call as a Segmuller or a Venkateswamy flap. And if it's a dorsal oblique flap, or if there's more dorsal loss, then you can do a reverse cross finger flaps in these cases. Atasoya flaps, again, we call it maximum registrar benefit, where it doesn't move more than 5 millimeters. Anybody who says that I've done about a centimeter of flap, I don't think he has done the Atasoya flap, or he has done what we call as a Tranquillity modification, which was described in 1935, where you can extend these two V's proximal to the DIP joint crease and then dissect the branches coming from the digital arteries at that part. You can't do a large VVAC flaps in the fingers because the dorsal supply of the finger is based on the volar supply. They come obliquely from that. Though you can do that as we know in the Moberg flap in the fingers as well. So Moberg flap, this is taken from Alpras, which we have written for the plastic surgery unit. Those who are training in the plastic unit, they can access this free site for teaching and learning. And Moberg is a large VY flap on the volar aspect of the volar defects or the tip of the thumb. And here you can do a large VY flap, and then we have different modifications. I like to do a unilateral hemi-Moberg, so to try to keep the incision on the real aspect rather than preventing incision on the ulnar aspect, to prevent any problems with the sensitivity around the pinching part of the thumb. This is just to show if the defect is on the dorsal side, you can do what we call as a reverse crossing the flaps, like an open book. You open the skin graft and then you take the adipofascial tissue, put the skin flap back, and then put a skin graft on top of it. So for dorsal defects, we do a reverse cross finger flap. For volar defect, we do a proper cross finger flap. The more you do, the more you get better at it. And these are quite robust flaps. They survive very well. So if you want to keep the flap, I'll recommend the paper by Mr. Elliott, where you can raise the flap, and if there's a volar defect, you can also do a flap like a reverse cross finger flap and open the clear ligament here, and then put the adipofascial tissue on the volar side and put a hypothenar dermal graft to replace almost like for like in these cases. Just to show you some examples, what I was saying earlier, if you have a defect on the volar side, you do a classic cross finger flap. If you have a nerve loss, you can take the dorsal branch in this to make the flap sensate as well. And that's the only criticism of skin grafts, is they're not sensate. So this just to show you the Moberg flap. So you can just raise it like a unilateral on one side, on the radial side, and then extend it like a hatchet on that side. And if that doesn't cover it, you can open the ulnar side as well in those cases. For oblique defects, you can do what we call as a Venkateswamy flap or a segbular flap. Again, Mr. Evans has described technique with the Z modifications to avoid contractions on the volar aspect in these cases. And Fouché has described for the volar defects in the thumb on the first dorsal metacarpal, based on first dorsal metacarpal artery for these defects as well. This is there are different variations of the flap which was described by Quaba in British Journal of Plastic Surgery. This is the dorsal. It's important to understand. I will highly recommend the book by Cormac and Limbati, where they describe the different blood supply around the hand, both the dorsal and the volar aspect of the hand. And the more we get comfortable with the dorsal blood supply, the more it's easy to do these flaps. This is based on the dorsal metacarpal artery. And the variations was described by Quaba. I'll show you some of the examples. We have modified this. This is a common injury which we see, circular saw injuries, where multiple fingers while gardening, if the sun comes out, a lot of people do DIYs and gardening, and that's where they get this kind of injury, where multiple injuries on all the dorsal aspect of the fingers. We published this in 2007, where we do a large view of flaps. It's all based on these perforators, which on which the Quaba described, and we raise and we extend the flap simultaneously to cover all these defects. Make sure that you on table, you check that the full flexion is achieved before you close it, otherwise it will be too tight. And then they will develop extensor contractures in these cases. This is published, so you can take, this is taken from the journal, but this is a defect from the volar on the dorsal aspect of the DIP joint. Quaba flap doesn't reach to the distal part of the PIP joint. So it can reach up to the proximal part of the PIP joint, but it doesn't reach up to the distal part of the PIP joint. So these flaps are useful for that. If it's only one finger, you can just do a large hatchet flap on the dorsal aspect as well. Just show you the post-op result, how the hand looks post-op as well. This is just to show you a case with the infection. Once you've debrided and washed out the wound, then you can mark out. This is Mr. Savapathi's modification, marking like taking like a small junction of a V, which prevents, it's easy to turn it over like a propeller flap, but at the same time decreasing the venous condition in these cases as well. Again, just to minimize the loss of PIA flaps. Show you the post-op result. Another case where I was involved, again, complex trauma, every composite defect, tendon, soft tissue, bone, periosteum loss. So as we say for graft, for trainees and audience, we say, what is graft loss? Where we use grafts? When there's a bare bone, loss of periosteum, loss of perichondrium, and bare bone, bare cartilage, and neurovascular structures, you need a flap tissue. You can't graft those areas. In this case, we planned one-stage reconstruction. So what we did was like a chimeric flap. So the ALT was planned, and we put silicone. Once the debridement was there, we put the silicone rod in these cases just to make sure that silicone rod was applied at the same time. And just to show you the post-op results of these patients, achieve very good results. Just to minimize the number of operations in these patients. You will see a lot of different flaps. I will run through them because the dorsal blood supply is independent. You can mark flaps independently. You can Doppler them and then turn the flaps around those Dopplers. You can give an exploratory incision, identify the perforator, and then mark the, so almost like a freestyle perforator flaps. Rotation flaps, not great, good for scalp defects, but if the skin is loose, you can plan large rotation flap or a transposition flaps on the dorsum of the hand in elderly patients with a loose skin. Mainly in cancer patients, we do that. This paper comes from my friend Gunnar Vipulapati in PRS in 2005, where they looked at how we can make the Quaba flap or how we can extend the Quaba flap as well. So I'll highly recommend this paper as well, just to show you how do we do. This is a reverse cross finger flap. We just raise the skin flap on one side and as an open book, and raise the adipofascial tissue on the paratinol on the other side, and then apply a skin graft in these cases. Just to show you another case, in young patients and children, you can do a thinner flap like an H over that area and raise that, but there is a risk of PIP joint contractures over these cases. Definitely not for elderly patients because it can cause severe PIP joint contractures. A lot of these cases have been done. We've done this in Sierra Leone as well, where you can use a abdominal wall tissue, both as random pattern and axial pattern as well. In this case, you can use as a groin flap, large groin flap. The part which is distal to it is a random pattern, but in the base of it, it has an axial pattern as well. You can also, if there's a complex defect, you can do 2-in-1 flaps. You can raise a hypogastric flap based on the superficial inferior epigastric artery, which can be applied on the volar side, and you can do the take the lateral flap, which is based on the superficial circumflex iliac artery, and apply it on the dorsal side. So it's more like a sandwich flap, and it acts as a good hammock, and the patients can walk about with this. The only problem with this is the hand is in dependent position. The fingers become quite swollen, and again, for social reasons, not a good flap as well. But you can modify this by doing a large, what we call as a periumbilical perforators flap. It's basically a DF flap, which is based on the deep inferior epigastric artery perforators. And you can take that flap 10 centimeter around the umbilicus and then raise it up to the angle of scapula. That long pedicle, again, the blood supply is described as far back as in 1984 in Cormac and Lamberti's original publication. You can also do these flaps when you have multiple defects. These are again random pattern flaps, but you can make them axial pattern as well if need be. These are being used for breast reconstruction. The intercostal perforators flaps, very popularized now, but you can Doppler them and then raise them as well. And then these are slightly better because the hand is more like a sling in these cases. So they're not in much dependent position. They're slightly better. And then in 2 to 3 weeks, you can divide the pedicles as well. Briefly mention this as a lack of time, just for complex reconstruction. Again, popularized by my friend William, using mini free flaps, replacing like for like. So the palmar aspect of the hand is a specialized tissue. So if you want to replace that like for like, you can use medial plantar artery flaps. Again, my colleague here in Manchester, Jason Wong, does a lot of these flaps, and William in Edinburgh does a lot of these flaps. And we have used some of these techniques with the venous flaps as well, but they don't replace like for like as in these cases. In complex reconstruction, if the skin and soft tissue and the joint is gone, you can use a free vascularized joint transfer as well. So you can raise the bar as much as possible. Is based on what facility is available and where you're working. This is to show you the complex reconstruction for elbow cover, and I'll end up with this case to just show you can do a free lateral arm free flaps. Again, it's not a dominant artery, or you can base it on a reverse lateral arm flap for elbow cover as well. I'll stop here because of, I'll pass it on to my colleague Jacob. I think he's going to present the West African perspective of soft tissue cover. Steve, we can't hear you. You mute.
Thank you. Sorry everyone. So thank you, Anuj, for getting across an awful lot of information there. The presentations will be posted on the BSSH website with a link to the whole of this meeting. So some of you, I'm sure, will want to view that again, because there's an awful lot of stuff to learn from in there. If people have got questions for Anuj whilst Jacob's getting ready, could you post them in the question and answer function, and I will ask him at the end of the presentations. So, thank you, Jacob. That was the UK perspective. We've now got the West African perspective, which will be a very interesting compare and contrast. So off you go, Jacob.
Thank you very much, and welcome to everyone once again. Sorry, I was put off by network issues, but thank God I'm back now. I think my work has been made easier by Anuj's presentation, and I will give the West African perspective as we go on. Because of their constant use, the hands are often injured, and since the exposed part of the body, usually it's difficult to hide them. And so it becomes a little difficult for patients to manage. Wounds in the hand can result in serious consequences affecting the ability to do either simple or complex tasks. And so soft tissue reconstruction is key in replacing damaged tissues or protecting exposed structures. I'm sure Anuj has gone through the anatomy of the hand, so I won't take too much time on that. The arterial supply, the nerve supply, the zones. But it's important to note that there are differences in the volar and the dorsal skin, especially in Black population. The volar skin being more pigmented than the dorsal and thinner also. Otherwise, the other features I think are eventually about the same. So usually for reconstructing like to like, especially when resurfacing palmar wounds, it's important to be sure that you get tissues that can resemble what has been lost. Now we're all aware of the functions of the hand, and like somebody would just simply put it, that the hand is an instrument through which we reach out to the entire world. So there are different scenarios in the West Africa where we see defects of the hand. We see patients following infections, especially necrotizing soft tissue infections of the hand. We see patients with tumors of the hand that following excision will require resurfacing, especially those patients that have suffered burns wounds and have chronic scars, unstable scars, eventually resulting into margarine ulcers. But I think the large bulk of our patients are from trauma, usually following road traffic accidents, burns injuries. And in West Africa, especially the center where I practice, we see a lot of animal bites. And with civil disturbance and unrest, we see a lot of cases of assault these days too. Of course, there are injuries resulting from industries and all of that. So there are certain peculiarities for poor socioeconomic societies like ours, including poor maintenance of vehicles, equipment, roads, predisposing people to accidents on the roads, as well as in the companies and industries where they work. Then the staff are usually poorly trained, either on driving, on use of machineries, especially the use of things like milling machines, grinding machines, and the rest of that. And then in West Africa, in many countries, our health insurance system is very poor, and so health financing is usually by cash and carry basis. And that leads to, amongst many other factors, to delayed presentation of patients. Now, it's important to know that for trauma cases generally, even as it will apply to the hand also, to manage the patients at the site of incidents, transport them to appropriate centers before eventually hospital management could be employed. And the hospital management will usually require a multidisciplinary approach. Not only the plastic surgeons, the orthopedic surgeons, like Anuj mentioned earlier, nutritionists, because some of our patients come with nutritional deficiencies, nurses, physiotherapists, hand therapists, occupational therapists, and the rest of them. It's important to preoperatively evaluate those patients properly and then do good intraoperative principles, as well as post-operative rehabilitation. So in trauma cases, it's important to note other injuries that the patient may have that may be life-threatening over the limb. And sometimes wound preparations may be necessary in the form of dressings and debridements to keep the wound ready for eventual cover. In some institutions, negative pressure wound therapy may be available, but power supply is a constant problem in West Africa. And so that sometimes can be frustrating. Investigations and clinical pictures are very important to be taken at all levels of the treatment. It is important preoperatively to discuss in details with the patients so that we also know the patient's realistic expectations. Some patients believe that when plastic surgeons operate, there are no scars at all. And so we need to discuss what the expectations are, what the available options are, and then before the patient takes an informed consent. So the reconstructive priorities will include restoration of circulation where there is a limb-threatening vascular injury. Otherwise, soft tissue cover takes priority, and then followed by stabilization of bones and joints. Although in some instances, temporary stabilization, like Arnold has mentioned earlier, may be necessary in the form of K-wires or X fixations. And then restoration of nerve function and then tendon function. The goals of reconstruction are to restore a functional and aesthetically acceptable hand and to provide stable cover for those vulnerable structures and primary healing. Although in a few instances, for example, superficial tissue losses of the tips of the fingers, healing by secondary intention may suffice. Intraoperative principles usually will require an arm table so that the arm is fully abducted and the surgeons can sit around the table, and to consider the use of preoperative antibiotics either prophylactically or as a therapy in infected cases. Anesthesia will depend on the kind of reconstruction that has been considered, ranging from general anesthesia to regional blocks, bias block. And the use of tourniquet could be quite essential in creating a bloodless field for clear demarcation of structures. And I'm aware that a few of us are practicing Wallant now, wide awake local anesthesia, no tourniquet technique, but that is limited to small cases of tendon repairs, maybe digital end amputations and grafts, unlike extensive flap reconstruction surgeries, where general anesthesia or regional blocks may be needed. Now, there are certain considerations that we may need to look at for selecting the operative technique. And that has to do with the wound itself, the patient, and then the surgeon. So the wound size, the location, and the tissues involved, and cleanliness, and patient factors, handedness, time of presentation, occupation, comorbidities, and then surgeon's factors like surgeon's preference and expertise are all important to be considered. And so the option for reconstruction is guided
I think we appear to have lost Jacob, which I suspect is a Wi-Fi issue.
Okay, sorry. So yeah, you can hear me now?
Yes,
Yeah.
loud and clear.
Okay, sorry, I'm sorry about that. So we consider reconstructive ladder so that there are certain wounds that we don't need to operate upon. All we need to do is to dress the wounds, sometimes apply negative pressure wound therapy. Some can be closed directly, and then we move in that fashion. Sorry, I'm just trying to move the slide now.
Yeah, we have lost you. You probably need to share your
Okay.
slide again.
Yeah, okay. Okay, I hope you can see that now. Okay, thank you. So, starting from skin grafts, yeah, this thickness for split thickness skin graft is 0.012 to 0.14 inch. For dorsal defects, coverage, initial coverage with dermal regeneration templates may be needed, but or other biology substitutes, but that's not available in most centers in West Africa, just like mine. Palmar defects, like I said earlier, we usually require glabrous skin grafts. Most people use full thickness, but a few will use split thickness skin grafts. And the local flaps, I think I won't take too much time here. Anush has mentioned all this. Local flaps, thinner flaps, you showed this. Then regional flaps, reverse radial forearm flap. We use this a lot in our center as pedicle flap because we don't have the expertise and facilities for free flap. We occasionally also use reverse ulnar forearm flap as long as the Allen's test shows that the radial artery can adequately supply the hand. But I don't have much experience with posterior interosseous flap that Anuj has shown earlier. Distant flaps shown superficial inferior epigastric artery flaps. We use that sometimes in combination with superficial circumflex iliac artery flap, occasionally a sandwich flap, as you mentioned earlier. And then, of course, we also use a lot of random pattern anterior abdominal wall, chest wall, and contralateral arm flaps for the patients. We have no experience with microvascular tissue transfer. Other flaps can be used also post-operatively. Splinting sometimes is necessary, and it's good to position the hand to reduce edema, give analgesia, antibiotics, and adequate dressings. And sometimes secondary surgeries are needed in the form of debulking surgeries and scar revisions like the previous speaker mentioned. A few complications may be seen, and rehabilitation is key to a successful hand surgery, which I think Sarah will talk about after now. So the different scenarios, infections, trauma, tumor excisions that we see. And then it could just range from simple lacerations that involve neurovascular bundles and tendons that one to tumor excisions from the hand. When you have this, you don't have problems with tissue. If there's any problem, then it's the management of excessive tissue in the hand. And the important thing is to align the scars along the creases so that they don't cross at right angles. This is a patient with late presentation following bones of the dorsum, an extension of D4 that was covered by non-glabrous skin graft. Usually we extend the period of splinting to avoid recurrence. And okay, then this is a patient who had flexion contracture that we used glabrous skin graft. Sometimes if I don't use Kirschner wires, because that is additional cost to the patients, we just pass big nylon sutures through the nails and incorporate them into the dressing to keep the fingers extended for as long as we need. This boy is a cattle rearer that whose animals entered somebody's farm, and the man decided to punish him by tying his hands behind his back for 2 days before he was discovered. So he had necrosis of the dorsal skin on both hands. And on the right side, we used groin flap. On the left, we used radial forearm flap reversed. This one had squamous carcinoma, Magellan's ulcer on the dorsum. And this was also covered by a groin flap. This book is good for hand rehabilitation. So in conclusion, achieving good aesthetic and functional results following soft tissue reconstruction of the hand is possible in many instances. However, this requires multidisciplinary approach, and finances and other challenges could be a problem in the West African sub-region. Thank you very much.
Thank you, Jacob. That was excellent and a great contrast to Anuj. We're very fortunate, aren't we, in the UK that healthcare is free at the point of delivery, meaning patients arrive on the day of injury, and our hospitals are very well resourced with surgical equipment. I'm not sure all our surgeons, it doesn't necessarily stop all our surgeons complaining about equipment shortages and not being able to buy the latest thing. Could I ask people to post questions for Anuj and Jacob on the question and answer or chat function, and I will direct them. And we'll ask those questions after the next talk. I've mentioned how privileged UK surgeons are to be working in the National Health Service. Probably the biggest privilege is working with hand therapists. Jacob's mentioned the importance of rehabilitation, and that's what Sarah's going to talk about. But certainly in the UK, you're not regarded as a proper hand surgeon unless you have an excellent hand therapist working in your unit. So over to Sarah for her talk. Hello, Sarah. Your slides are clear.
Yep, sorry, hear me now. So I'm very privileged to be able to talk to you all today. I'm very lucky to work in a big hand and wrist unit in London with 17 hand therapists, 10 hand surgeons, and we're able to work all the time as a team. I've worked in hand therapy for 30 years, and probably the thing I've appreciated most is being able to work in a team and have all the discussions that we can with surgeons and the therapy team. So some of what I'm going to say will overlap with what Debs said last time about therapy. The role of the hand therapist in soft tissue cover is very similar to what you heard before. So we're very much there to try and prevent complications associated with edema, stiffness, pain, nerve compression, hypersensitivity, restoring an early range of motion, and that's obviously where we're working very closely with the surgeons to work out what can be moved and how quickly things can be moved. Obviously with soft tissue cover, there's a large part of scar, graft and flap management, and obviously restoring function. So the biggest thing in the end is actually to get people to use their hands. And Jacob said in an excellent way how important hands are, and if people can't function, then they can't lead their lives. So I've looked at early hand therapy. So if we can see those patients, so I've got one very small full thickness graft just to show a splint that we've made for it. But in the early days, where our job very much is to protect soft tissue cover, to allow healing, to prevent contracture. And that's positioning, splinting, stretches to try and reduce any contracture forming as you heal with a scar or a graft. Aiming for a position of safe immobilization, which I'll mention again, elevation or movement for edema, and move everything that you can. So you can see in this splint, we've only splinted the finger involved, so the rest of the hand moves. Where you've got here a forearm flap coming through, we've made a splint that allows the extensors to glide and move underneath, but blocking the areas to make sure that the flap here is not compromised, but allowing some movement to allow tendon glide. So we're very much there to try and get that early stage of movement. Probably the most useful thing for hand therapy ongoing is to try to position the hand in the best position possible in theatre. Now, it's often not possible to get a lot of MCP joint flexion because of the length of the flap, but the more you can get towards a position of safe immobilization, the better the position of the ligaments, the tendons, the soft tissue, and the easier it is for us to get them moving afterwards. So just using basic plaster of Paris and a bandage. And if you can, and if the hands are rested in that position for 1, 2, 3 weeks, however long you think you need, it can make a huge difference to the end of their function, range of motion, and us getting them moving. This was us in Malawi last year doing a teaching session on plaster of Paris with all the therapists. So we taught both the surgeons and the therapists to manage those easy position of safe immobilization splints. Once the graft or flap is healed, so I could only find a picture of a very small graft again. Obviously, if this were healed, we're managing edema, we're managing scar. We're trying particularly to gain tendon glide, so everything tethers underneath the flap or the graft, gaining passive and active range of motion, and managing hypersensitivity. All skin cover will go through a period of hypersensitivity, even if there's numbness initially, and encouraging use of the hand as much as we can. So I'm going to look briefly at each of those in turn. Edema management, I think Deb's looked at this last time. Elevation, use of passive movement, active movement, and in particular spreading and bringing the fingers back in ab and adduction gives you the best pumping action for edema. Scar management. Massage is something that everyone can do with oil or cream. It's partly about moisturizing healed scar and flap. You want to go deep into the scar as well to start breaking down some of those edges of the scar, shearing the scar sideways to get movement. Use of vibration is another very good way of breaking scar down, helping to prevent hypertrophic scars from over-thickening. And do massage before you exercise, because massage warms the tissues, stretches the tissues, and allows you to move better. If you get an opportunity, compression, we know, makes a really big difference for flaps and for helping to get rid of the fluid and some of the adipose tissue underneath. So any sort of compression with any sort of elastic bandage, even just a tight tuber grip, or you can use socks, anything that has a little bit of give to it, you can tighten them in order to provide a bit of compression. Stretches and gels if you have them. So managing that flap and graft, and maybe over 6 months to a year, you may need to be continuing to work on those. Moving tendons. This is Deb's mentioned last week, tendon gliding. So getting the fingers moving in patterns so that you keep the flexors, extensors, and intrinsic muscles moving. Use tenodesis. Use the fact that wrist flexion helps to extend the fingers. Wrist extension helps to flex the fingers. You can use really simple exercises, just rolling a pencil up and down in the hands, or if you don't have a lot of flexion, roll something bigger like a water bottle, and that will get tendon glide, that will stretch the skin, stretch the scar, and it's simple for anyone to do with no equipment at home. So also work on resistance. So one of the biggest problems, one of the ways of trying to get healing grafts and getting tendons to glide is to produce resistance. So simple things like a piece of foam in a pair of tweezers makes the flexor tendons work a lot harder. The stronger the flexors work, the more the extensors will passively stretch, the more the skin stretches dorsally. Use just pulling something along a Velcro board. Again, will stretch all the tissues dorsally as the flexors work harder. So bringing in resistance is a way of getting everything to glide better and stretch of the skin and the soft tissue cover. Also looking at gaining passive and active range early. So in the early stages where as soon as the flap is safe, get everything moving as soon as possible. Passive is very effective initially. So here we've got very tight skin following grafting. Patients can do passive. They need to hold for 30 seconds to a minute. If you do a lot of passive, you want to follow up with active. Stretching in different directions will gain glide. Grafts and flaps, again, need to be put on stretch in order for them to elongate, to allow for better movement. And then I think we find with a lot of patients, they have hypersensitivity and a loss of function. So we want to desensitize those areas as soon as they're healed, working with massage, creaming, oiling. These textures, just lentils is a fantastic way. Wet the hand, put the hand in the lentils, and then move the hand around to rub the lentils off. And that gives good texture sense. That rubs different sensations on the skin, but it works on range of motion at the same time. You can use different texture sticks or just use textures at home, rubbing across the area to settle the sensitization. Use temperature, use hot and cold. Use things like soap to try, it's very slidey, so it slips very easily. That gives good proprioception, good information to the hand, to the brain about what's happening in the hand. Use functional activities, roll balls. So just roll a little ball or a rolled up piece of paper, a pebble. Again, rolling them around the hand, different textures is very good for the sensitivity. And then use the hand as much as possible in function and in all the different grip patterns, span, pinch, tripod pinch, spherical, hook grips. So just maximizing using activity and function to gain stretch and movement of the flaps and grafts. You can put the whole hand into a bowl of textures in order to help again with desensitization. Use resistance, use pegs is another very good way of gaining stretch and movement, and it also adds texture. Splinting for stiffness. So we know with a lot of these big injuries, they're going to be stiff, and there's not a lot we can do to change that in the early stages. So if we can position well, that makes a really big difference. But we know these patients will have fixed flexion deformities. They will have stiffness at the MCP joints in particular at gaining flexion. That's a real struggle with the dorsal capsule. So again, plaster of Paris works really well. You can just wrap a little circumferential plaster of Paris, leave it for a week, soak it off, replace with another one. And slowly over week by week by week, you can serially stretch out a joint that's very stiff. It happens very slowly. It may take weeks and weeks, sometimes months, to make a big change on a big joint, for example, an axilla, an elbow, or a wrist. Now, this is made out of thermoplastic, but you could make this out of plaster of Paris. So just again, a stretch splint for the web space, a C-bar. And if you make that out of plaster of Paris, they can put it on maybe at night only. Function, move, exercise, massage, do all the other therapy in the day, and then they slide it back in at night so we don't sleep with a hand clenched. You gain stretch overnight or for periods in the day. And all of these stretch splints you can make out of plaster of Paris pretty easily. Ideally, just to say, you need at least 12 hours of stretch in 24 to make a really big difference to stiff joints. So you need to find a way of getting really good stretch for many hours. So in conclusion, thank you very much. I think early, get your therapists involved in moving everything that's safe to move, active and passive, get good plasters on in a position of safe immobilization, and then let the therapist work with the patients on a home program and a program in the department for desensitization, range of motion, scarring, and getting stretch. Thank you very much from London. Oh, just to say, I've got a teaching website. We have some online courses. We're very happy also to have emails about clinical advice. So if anyone's interested in sending some emails just to talk about cases or consideration, please contact me via that website.
Thank you, Sarah. That was excellent, very clear and concise, and I do hope you will encourage both your colleagues and therapists to use that website. If you have managed to get a hand therapist in your unit, do look after them, develop them, cherish them, and keep them. it will make a huge difference to the surgical outcomes. So now I've got one question now. Anuj has already answered one. Another question for Anuj about the use of combined radial forearm and posterior interosseous flaps.
We can combine them. Most of the times when we have combined it, we've done as a pedicle flaps, as I mentioned earlier, and I've shown one example as well. If you're doing pedicle flaps, if you're doing a groin flap, it makes sense that we do a hypogastric flap as well. So we do a hypogastric flap from superficial inferior epigastric artery for the volar skin, and do the groin flap for the dorsal skin. So it's more like a sandwich flap there. You can do the same thing for posterior interosseous artery flap. I think to answer the first question, I will see if I can share the screen again, just to show you that example of the fascial forearm. I'll just take 1 minute. Because of the lack of time, I didn't want to go on with that. If I can see if I can share that screen. Minimize this. I think one of the colleagues asked about this question, so I'll just show the example there. So this is a case of a burn contracture. Again, I saw a lot of cases with burn contracture, and if I can, I'm not sure whether this screen works. Am I sharing the screen?
Not yet. No.
Fine, let me just share the screen. Sorry. Yeah, share screen, and yeah. I think it can show, like this case, I think one of the questions was regarding using fascial forearm flaps. I think this is working now. So, and you can see it's a post-burn claw deformity or the intrinsic minus hand. And as I was saying earlier, we try not to start, we always start with the winner. So proximal to distal, if there's any axillary contractures, elbow contractures, do them first, wrist contractures, then MCP joint. First web, thumb is 40 to 50% of hand function. So releasing the first web space and thumb is very important, then the MCP and then the PIP. Try not to correct the Butner deformity corrections as well. The question was radial forearm. So once we go through this, you can actually see how the hand is gone from that function. It's never going to be a good hand. It's more like an assist hand. So managing expectations, what Jacob was saying earlier, is important. Convert that intrinsic burn, post-burn intrinsic minus to an intrinsic plus hand is important there, just to show the different variations. And you can see the joints are subluxed as well. So there is a joint contractures as well. We do different approaches. We do an incisional release and then fishtail on both hands, retract the tendon. As the joint is subluxed, releasing the joint capsule is important. So doing a dorsal capsulotomy in this case is important. And planning it before, and the first phase, web space is released as well at the same time. And you can see there's a big defect there. This you have to anticipate beforehand before you start doing it, and it will always need a flap. You can do a posterior interosseous flap there, but I think they don't reach the distal extent of the MCP joint, so they may be short of it. So planning a radial forearm fascial flap is a better option. In this case, we have done a radial forearm fascial adipofascial flap just to add some more strength to the thickness to that. Sometimes the fascia is so thin you can't you perforate it at multiple places as well. Again, it's a dominant artery checking. You can see in this case, it's showing how thin it is, and you've added a bit of adipose tissue into it as well. And you have, because they have got memory, we have used K wires here to maintain the intrinsic plus hand, change the hand from that position as well. And you try to use the same fascial flap to cover that as well. The disadvantage, yes, it is less bulky, as the question was asked earlier, but you can, I'm not sure whether I can show you that case, last case, where we published that as a pre-laminated flaps in PRS. So you can pre-laminate them beforehand or prefabricate them beforehand to decrease the bleeding in these cases and make them less bulky, and they are slightly better. And then you can start rehabilitating further without the fear of graft loss in these cases. So yes, you can do both PIA and radial forearm. I haven't done both at the same time, but I've done hypogastric and groin flap at the same time in the same patient simultaneously.
Okay, thank you. Do feel free to post any questions as they arise. If I can now ask for Lucky to screen share, we will attempt to reinforce a lot of that knowledge that was put out there by Anuj and Jacob in some case-based discussions. Welcome, Falaki. For those of you who don't know Falaki, she's a plastic and hand surgeon in Lagos, a leading figure in Nigerian plastic surgery and the West African College of Surgeons, and who really hosted us very well in Abuja in February this year.
Good afternoon, everyone. Thank you for joining the webinar. We'll have some cases to share and for discussion by the panelists. I'll be going through a few cases. This is the first case that I'll be showing. Like Jacob has said, there are a lot of trauma cases which we see in Nigeria, and many of them are due to, many of hand injury cases, and many are due to trauma. This is a case of a 23-year-old right-handed man who is right-hand dominant, who sustained injury to his hand 6 hours before presentation. So here's the picture of the hand. I'd like Anuj to please give us his view of how he would like to manage this hand injury.
Yeah. So applying the first principles, again, assessment is very important. With these kind of injuries, they can be very, for trainees in the audience, I'll say hand injuries, burn injuries, they can be very distracting injuries. Not forgetting the ATLS principles is very, very important. So if it's an isolated injury, then concentrate on that hand, but applying the ATLS principles is the key. Sometimes when we see a chopped hand, chopped finger, we easily get distracted. It happens to all of us. Just reminding ourselves that hand is not in isolation. So the patient attached to that hand is important as well. In this case, the principles again is to assess what length of thumb is present, how much of index finger is lost, what is the loss in the index finger. And sometimes, as I said earlier, thumb and first web space is 40% to 50% of hand function. So sometimes we can use, this is the one which I have published in called component separation. Because index finger is not as important. Yes, every finger is important. And when you talk to the patient, they, at the time of A&E, if you say you are going to lose this, sometimes they start panicking. So proper assessment is important. Giving them a realistic expectation is important. An overall view is important, whether I can't see whether how much of index finger is left. But sometimes what you can do is whatever is left, we call that spare part surgery. So if the index finger is almost gone, you can take whatever the index finger is left or the soft tissue of that index finger to maintain length. So there are 7 requirements of the qualities of thumb. So length of the thumb, strength of the thumb, mobility of the thumb, sensation of the thumb, all these are important qualities in thumb. So we can take those portions of the index finger. Sometimes we can take a portion of the index finger from that, whatever is left, what we call as spare part surgery, and reconstruct whatever to maintain the sensation, the length, the mobility, or the joint. Sometimes we can use part of the joint as well. So what I've done is I have taken the joint of the MCP joint of the index finger on the ulnar artery and the soft tissue filleted around based on the real digital artery, and reconstructed the length of the thumb and maintained the length of the thumb for those cases. And then shorten this at the level of the base of the index finger, because you don't miss the index finger. And if you try to make reconstruct the index finger and don't maintain the length, they have a stiff index finger which they don't use, and the brain bypasses that index finger as well. But at the same time, it comes at the cost of losing a finger as well. In a lot of cultural things, people don't want to lose finger as well. So that has to be important as well. Take that into consideration. Again, we always say about discussing it, saying this will be more like an exploratory incision, will come back. And a lot of times we are doing, as we have now, we know, we're doing a lot of volume surgery. So we give an overall view to these patients, and then during surgery as well, we talk to them. We are also doing it under block. Again, we can also inform them. A lot of patients don't want to see it, but a lot of patients do want to. At least my experience is 10 to 20% of the patients want to see, and then we can discuss it during the operation as well. Sometimes we have to do it in the GA. In that case, it's better to do a more like an exploratory incision and do what's best for the patient, and then come back and plan that reconstruction formally. Sometimes these are very dirty wounds. The agricultural wounds, you need to make sure that all the debridement is done, assessment is made, and then plan what I was saying as a second stage. So you can do a final debridement and then do the reconstruction in those cases.
Thank you very much, Anuj. Jacob, I like your comments. Just to say before Jacob speaks, in our culture, many people don't want to lose their digits. In fact, you see crushed digits and the patients still want them to remain there. So that usually is a problem. Jacob, I like your view on how you like to manage these patients.
Yeah, thank you very much. I think I agree with the two of you on your views. Let me just start from the point you raised now, that sometimes some patients are not ready to part with their fingers or any part of the body for that matter. So sometimes it's good for them to end the surgery. You know, you do what you feel you can do, and then at the end, if they see that what their desire was is not helping much, then they can now agree on what you do. It appears as if the pulp of the thumb is lost. I'm not sure whether it's lost or it's some blood over there. Otherwise, after resuscitation and all the assessments of other structures, it would be nice if one could do a mobile flap if the pulp of the thumb is lost. But again, I can see what looks like a scar or an incision around the proximal parts of the hand. If that crosses towards the thumb, then that mobile flap may not be possible. Otherwise, for the rest of the wound, usually what we do is at this position will be like random pattern chest or abdominal wall flap. Sometimes the state of the wound is not what delays us, is the funding for the surgery. So you may want to operate and do what is necessary at that time. But if the funds are not available, then you are just forced to wait. And there are a good number of times that one would have loved to use one flap or the other, that eventually the delays lead to granulation tissue formation. And eventually what you do is just to skin graft the wound. But that usually will lead to stiffness, except tedious rehabilitation. And physiotherapy of the hand is enforced at the early stages as the pains will allow.
Thank you. Sarah, I would appreciate your inputs and the rehabilitation of this hand post-reconstruction. You're muted, please.
I'm there now. I would agree completely that the thumb is by far the most important. A stiff, often insensate index finger is very easy. It's very hard to get patients to use it effectively. But as you say, sometimes you need to keep it, and we then just work on moving the thumb towards the middle finger. I think, again, thumbs are very sensitive. You often have a lot of trouble with getting the thumb back into function because of sensitivity. And I think if you end up having to do a chest flap, abdominal flap, really in the early stages, all you can be doing is just keeping the fingers that aren't involved moving as much as possible, trying to get rid of the edema as much as you can. The more the hand can be slightly higher, the better. Once skin cover is safe, we're very much then working on function. So often, again, you can work on active and passive movement, but the best way to get a severely injured hand like this is to use function. So to get them moving within activity. So you're working on the sensation the movement, and it's much easier for someone to get movement by functioning than necessarily by doing exercises. The thumb, very much, I think we know the first web space is really important. So particularly if you don't have an index finger, you need to keep that web space nice and wide. So in abduction, but also in extension. And so splinting within that web space at night, in particular, is a way of keeping it separate, keeping it wide, so that they can function well with a span for their hand. And I think I can see that there's, you know, the MCP joint, MCP joints of the fingers are likely to be very stiff as well. So you might need to be resting all of the MCP joints in a good position of safe immobilization with a thumb web space. So if you in surgery, if you can, depending on how you're managing this, or if you have delayed surgery, then it's very important to rest them in that position of safe immobilization if you can. Does that answer well enough?
Yes, thank you, Sarah. So the role of the hand therapist is very important right from the beginning of a management. Attitude, this is an acute injury, 6 hours post-injury.
Yeah.
So
yeah, absolutely, thank you.
Yes, thank you very much. I'll go to the next case. 26-year-old right-handed dominant man with 2 hours injury to the tip of his ring finger, right ring finger. Jacob, how would you like to manage this patient?
Okay, thank you very much. This appears to be a simpler one compared to the other one. And the other parts of the entire hand appears to be safe, although the distal phalanx is lost and is beveled to the volar surface. If the bone is not jutting out, I think one would just flip back the dorsal skin to close the wound. Because in our practice, I know that many of the patients will insist that this finger has to remain. On the other hand, one could gain some little length by putting a flap from somewhere. Like I said, one of the flaps you can use here is the hypotenuse flap, which is proximally based around the crease of the thumb. Like Anush mentioned earlier, sometimes if it's not well positioned, it can cause stiffness of the MP joint, but hypotenuse flap should be able to cover this. Otherwise, one could also use a random pattern abdominal or chest wall flap.
Anush, how would you like to manage this?
I was just trying to answer the case which we did by posting it on the Q&A. So if I agree with Jacob, so you can use, if it's a young person, then you can do a thinner flap. But in elderly patients, I try to avoid thinner flaps because they can cause PIP joint contractures. If it's a volar defect, then it may need a cross finger flap. As Mr. Elliott has written a very nice review article in the Indian Journal of Plastic Surgery on homodigital flaps, trying to keep the flap on all in one side. If it's a volar, it's a lateral oblique flap, then you can do either a segmular flap or a Venkateswamy flap from the same digit, so a neurovascular island flap to give soft tissue cover on that. Sometimes it's not very clear from the picture whether it's a volar. It looks more like a volar defect, then it needs a cross finger flap. If it's a lateral oblique flap, then segmular flap or a Venkateswamy flap with a Evans modification can help to prevent the flexion contractures in these. It's very important to, if you're using a straight line, we say in plastic surgery, straight line is the enemy of plastic surgeons, but if you're going obliquely, you can avoid flexion contractures. I think my friend Rebecca has asked how to avoid flexion contracture in these cases. Then you can do like what we call as an Evans modification, like a step cut. or come back later. Just allow it to heal first, and then once they've had therapy, the swelling goes down. We don't want to make the operation very complex. Come back and do Zs in those contractures later on.
Thank you. There's more tissue loss in over the dorsum of the hand than the volar, and the bone is not exposed. Is there room for glabrous skin graft over the stump?
My personal belief is that skin grafts are not good options for fingertips. So yes, you can use it. I will not use a full thickness skin graft. Full thickness skin graft doesn't contract. So a thin split thickness graft allows the wound to heal faster, allows the wound to shrink. If the defect is less than a 1 centimeter square, it heals by secondary intentions. Very surprising, it heals so well with secondary intention, and then pulls the good quality skin around it. So the final, when we take pictures over 3 weeks and 6 weeks time, they look far better. Those who are self-employed want to go back into work quickly, then sometimes they push you for other things as well. But using a duoderm dressings and showing them how to do the dressings and keeping the joint supple, I think is the key to not to do grafts in these cases.
Sarah, please could you advise on the physiotherapy for hand therapy for this patient?
Yeah, absolutely. I think one of the things just looking at the length was whether the insertion of the FDP is still intact or whether that has been lost.
It's still intact.
Okay, perfect. So that makes a big difference, obviously, that you will get a little bit of power if you can get that pulp healed over. You then end up with a much better fist. If you don't have the pulp or an FDP to the ring finger, you can lose certainly 10–15% of your power in grip. So it has quite a big impact on function. I think initially we're always very aware that the PIP will contract. And so to rest the finger in extension, and you can do that just with a little Zimmer splint or a lolly stick or a bit of wood or anything that fits onto the back of the finger, again at night mostly, so you can get moving. Most of the time with a tip flap, if you've been you can move pretty quickly and pretty early on. I would do some passive movement. So passive is really initially for the joint. So the PIP, you can work on maintaining, gaining that passive movement. You can get passive MCP joint extension and flexion. You then want to bring in active, because active is what gets the tendons gliding. So you're obviously going to get scarring. You've got a lot of swelling, which means that particularly the flexor tendons don't glide well. As soon as the tip is comfortable enough, you want to look at different tendon glides. So you want to get FDP glide to start to get some DIP joint movement, maintain the MCP, particularly work on FDS. So you want to work on getting just that PIP pulling down, because that's going to give you good power in grip, even if they don't get very good DIP joint flexion. And then of course, fingertips are very sensitive on recovery. So function, massage, textures, desensitization.
Thank you, Sarah.
Thank you. There's been a question from the audience from Mr. Colville from the UK. Probably a question for Anuj, I think, about an ulnarly based Houston advancement flap.
Yeah, we can do that as well. Good option.
Do you want to just expand on that a little bit?
Again, that's why we say, I think Mr. Colville has mentioned, historical flaps are very important, and that's why we teach about history. I deliberately taken the slide out. I'll try to find that flap, Houston flap, and show it if I can find in my presentation. Because of the lack of time, I did not mention it. But when you were mentioning it, you can take a flap from the side of the finger and turn it around. It's a good option. So sometimes we use it for depressant contracture as well. If the tendons are exposed, we can take a small flap, and then it's like a transposition flap. So you just take a flap, like a tongue of tissue from the side, and then turn it in. Just be careful is to keep to avoid neurovascular bundles. I don't use it. So if I have to use a flap from the side, I do like an open book flap. So I take a flap from the dorsal side, adipofascial tissue. So if my volar tissue is exposed, I take open it's almost like a reverse cross finger flap. So raise the flap, skin flap on the dorsum, then take adipofascial tissue, open the clear ligament, and pass the adipofascial tissue underneath it. So it covers my FDP if the volar tissue is exposed. And then take a hypothenar graft and put it on that adipofascial tissue. And it looks, if you look at the patient 3 months down the line, you will hardly see any scar, or you can't identify that they had an operation in that area as well. So I prefer that option, but Houston is a good option as well. It's basically a lateral flap from the side. So like a transposition flap or an interpolation flap, to be more precise.
Thank you.
Okay.
I'll try to find a slide to show a picture of it as well. I think I have got a picture, but I took it out.
The next case is a 30-year-old expanded man whose hand was caught in a roller in a printing machine. Anuj, how would you like to manage?
Yeah, I think I showed one, for Lucky, I showed one case. We don't see it. The health and safety has become really good. When I was training in Chelmsford, we used to see, I think 15 years ago, we used to see quite a lot of reimplants and revas and bad industrial injuries. Thankfully, I think the legislation has improved massively. So our number of reimplant and revas has massively decreased, and to be good for the patient, but we still see them. So I showed one case with the rollerblade injuries. Very important, again, making sure that ATLS principles, no distracting injuries, and they can swell massively. So important to emphasize patients are panicking. So we're telling them, trying to convince them that they've come to the right center, being treated by the right team, hand elevation, assessment of the wound. So assessment of the wound is very important. So first operation is almost like an exploration, getting an X-ray done to rule out whether it's a pure soft tissue injuries or there are multiple fractures. A lot of times there are multiple fractures, and sometimes there are no fractures, but they swell massively. And they have got what we call as degloving injuries. And the degloving can happen at two different levels, a superficial degloving and a deep degloving. The best tissue is the patient's own tissue. So we want to maximize that, but at the same time, we want to be, anything which is dead and necrotic has to be debrided. So, and that comes with experience as well. The more you debride is almost what we call a pseudo-tumor excision. I think I showed one case where we just debride, anything which is not bleeding is debrided, and to make sure, if you're doing in a tourniquet, take a tourniquet down, check for the your assessment of whatever is dead and necrotic, debride it. Stabilize tissues. If there are fractures, you can use external fixators. A lot of times, as Lucky said, patients don't want to lose fingers. In that case, you can put a longitudinal K-wire just to act as an internal splint while you're planning the further reconstruction, and try to maintain the length in these cases. And then come back and do the reconstruction. Sometimes this is the first debridement, and then within 24 hours, you keep them hand elevated, come back and talk to them because they usually have a general anesthetic, if not block anesthetic. And that case, if you've not told them, tell them about the injury, and then tell them about the plan in terms of flap as well. If you're doing it in Sierra Leone, I think we have done abdominal flaps in these cases. I've shown 2 or 3 cases. We have taken few flaps. The defect is mainly on the dorsal side here. Once you've debrided it, assess whether there's a graftable bed or not graftable bed. If it's a graftable bed, yeah, and it's a superficial degloving, you can get away with skin grafts. If it's a deep level and the peritoneum is exposed, peritoneum is lost, then it may need a flap, which you can put it in abdominal, like abdominal glove. And we call that like a step ladder flap in the abdominal wall. And they are basically bipedical flaps. If you make holes, transverse slices in the abdominal wall, and then put the finger in there. So what you can do is you can put the hand in the area and give multiple slices, parallel slices, and then roll the inside flap inside. So the outside tissue act as an envelope, and they provide a sling for these patients as well. I think I showed one case like that as well. So you can use them for reconstruction, but that will be my second stage after 24 hours. That will allow us to make sure that you've done a second debridement as well, making sure there's no dead tissue, and then plan. At that time, we can plan that tissue, do a definitive flap reconstruction in this case.
Jacob, please, how would you like to manage this?
wound debridement will be important here. I can see that the middle finger of the, sorry, the middle phalanx of the fourth finger has an exposed bone. I don't know whether it's bone or tendon now. So that would be a little bit of a problem. But the tissues in between the metacarpal ends and the middle phalanges, we have to be watched to see whether they will survive or not. So that if they don't survive, because the injury may cause some collateral damage and vascular thrombosis that may make those skin not survive. So if that's the case, then well, we need to cover from D2 to D5. And like Dr. Anuj said, you may use, if that is the case, I will use something like a groin flap. But the problem with that is that you have syndactyly that you
I think while Jacob is coming back, I'll say that we always do a pseudosyndactyly of the in between digits so that they all join together, and then you do a cover on top of it. I'll still wait for Jacob to come back. I'll mention if it's a roller printing injury, be warned. I think Sarah will also mention that these patients have got massive swelling and ischemia of the intrinsic muscles. So watch out when they come back for therapy and in your follow-up clinics that they can develop what we call as the intrinsic tightness in these cases. So you can check that by bundle phenochetose test, and they may require that correction as well at a later stage. Sometimes they come back and they can have compartment syndrome as well. So watch out for compartment syndrome in these cases as well. It looks like they have got a burst laceration, but they don't decompress it. So watch out for those as well.
Sorry, I was lost somewhere there.
Yeah, you're back.
Yeah, I'm back. Sorry about that. Yeah, so otherwise, if the skin in between are intact, like Dr. Anuj said, one can use louver flap, multiple random pattern skin flaps from the abdomen or the chest wall, especially on the contralateral side to keep the upper limb in a more comfortable position. And in that position, the fingers, the wrist, and the elbow can also move gently. But again, that's also dependent on the age of the patient, because above 40, there tends to be stiffness of the wrist and the elbow after a while.
Thank you, Sarah.
Yeah, I would agree very much with Anuj on this, that one of the big problems with crush injuries is firstly the amount of edema that's caused, secondly the amount of pain that these patients have. So there's a lot of nerve compression. They often have a lot of neuropathic pain, which makes movement very difficult for them in the early stages. And quite rightly, the muscles that are often that struggle most are the intrinsic muscles. So if they become ischemic or they don't have a good supply for a while, you can end up with reasonable MCP joint flexion, but very poor IP joint flexion. And so we were just talking about testing. If you just go put the finger in a passive, so you should be able to passively flex, and you see that, the IP joints with the MCP joint in extension. And that shows, so that's one of the exercises that as soon as it's safe for us to get in and start doing passive movement, you need to work on this intrinsic, what we call intrinsic minus position, where you're working, and that will stretch the intrinsic muscles. We get working again early with intrinsic active. So this abduction is one of the best ways I mentioned before about getting rid of edema, because it helps to pump the muscles and it helps to pump the lymphatic system. So getting abduction again is very important in the early stages. Sometimes if you're resting them, you want the MCP joints in flexion, you might want to again relax the PIPs a little bit to take off the strain of that. With edema, you need to do a lot of elevation, a lot of as soon as the soft tissue cover is good enough, to do gentle massage. So gentle sort of stroking. So not forcing hard, but gentle stroking movements to try and help to get rid of the edema. With any exercise, you want to do passive followed by active. So presuming, again, I can't tell if there are fractures or anything underneath. So if you've got fractures, you're going to want to do more active to get the tendons gliding. You may not be able to do as much passive. I think getting the wrist moving is very important. So use that tenodesis effect to help the fingers to extend with wrist flexion, flex with wrist extension. And that gets really good tendon glide, because wrist movement encourages up to 4 to 5 centimeters of tendon glide through the hand. So get that movement going as much as you can. Encourage people to function, as soon as they're moving a little bit better, get them to function with a hook to keep the intrinsic muscles on stretch, and not to do too much of what becomes an easy extension grip, which means the intrinsics are working, but they're not on stretch.
Thank you, Sarah.
Could I just ask Anuj, you mentioned the importance of watching out for compartment syndrome. How do you diagnose that in an injury like this?
It's very difficult. I think watching out is the key. What we normally say is, when we have burst lacerations, people think, oh, he will not have compartment syndrome because the wound is open. But like any lower limb things, which we see a lot of times, we watch out for big muscles like that. If in doubt, when you're doing the debridements, you can do fasciotomies of the 10 compartments, as Sarah has mentioned. If you think this is going to swell, which in this case it will, and if I can show my first case, we did the carpal tunnel for that as well, and you can do the thenar muscles and hypothenar muscles as well. It's very underreported. I think most of the times these patients come to the therapist and they pick it up. Or when you try to look for the intrinsic tightness in these patients, then you can find out that these patients had they suffered ischemia of the intrinsics because of that. But at that time, we are just aiming to make sure that the length is maintained and the debridement is done, soft tissue cover is done. So a lot of times these are underreported. So it's not as bad compartment syndrome. I think Sarah will answer that.
Yeah, I just wanted to say as well that one of the reasons that we often pick it up when we start in therapy is, we know that if you've got a poor blood supply and you put a muscle on stretch, it increases the pain response. Yeah. So if in the early stages you're just doing this intrinsic muscle stretch, if doing that movement passively increases their pain response above what you would expect as normal, or above what their pain is, that's generally quite a good sign that you're getting compression as well in the area. But it doesn't always show if you just try active movement, because it's so limited at that stage. So do that passive intrinsic minus stretch across each, and they will get their pain directly in the compartment. And I think that's a good marker for developing compartment syndrome.
We're talking about chronic compartment here. So they all will have some element of it. And if the roller blade has gone more proximally, then you have to be very careful that definitely the carpal tunnel needs to be decompressed, and with extension into the forearm as well. If I'm doing a carpal tunnel and forearm decompression, I go and release the thenar and hypothenar spaces as well, because that's where the patients will have less chance of chronic compartment syndrome in the small muscles in the hand. And you can assess by what the test Sarah is mentioning, which we call as the Bernal-Finocchieto's test, to put the intrinsics on a stretch and then test it. Unfortunately, with the wound on the dorsum of the hand, the intrinsic tightness will, the extrinsic tightness will also overlap with the intrinsic tightness as well. So it's very difficult to assess whether it's extrinsic tightness or intrinsic tightness in these cases.
Yeah.
Thank you. Jacob, a 45-year-old man with an injury to his right hand. He has basically has of the tips of all his digits, including part of the thumb. How would you like to manage?
Yeah, this one will We make the initial assessment and determine whether he has proximally based fractures, which probably may not be likely here, because it appears it's a sharp object that transected the fingers. So here we need to debride the wound. It appears there are no phalanges left.
No phalanges.
Yeah, no phalanges left, right?
Of the fingers, all the fingers are gone.
Yes. Yeah, I can see a stump of the thumb.
Yeah, the
So
thumb.
one we try to, yeah, one want to preserve that as much as possible, debride, and then also determine whether you need to cover with soft tissues primarily or not. Otherwise, if the bones are not exposed and you're able to debride well, you can cover either with a split thickness skin graft or use a flap. In my own case, usually I will use a groin flap here.
Okay. Spanish?
Yeah, so sometimes we see these cases. They're not as often in UK now with the health and safety becoming more important. But this is what we call as a metacarpal hand, and we apply the principles here. So thumb, as we mentioned earlier, thumb and first web space is 40 to 50% of hand function. So it's a very distal injury in the thumb, which is good. So just debriding that part. Trying, if it's a sharp injury, making sure that if the patient has come, they've brought the part with it, if it's a sharp cut. So trying to reimplant that part is the best, will give the best result to these cases. So if they've come with a less warm ischemia of less than 6 hours or cold ischemia of less than 12 hours, I think there's no harm in trying to reimplant. It's a sharp cut. Also, if assessing, so bench dissection, getting, in UK, we have to make sure that the person who's taking the referral should make sure that the person who's transporting it understands it. So don't assume that the person who's transporting it understands how to transfer it. So put the part in a plastic bag, and that goes on a slush of ice and water, and then transfer it to a unit where they do reimplantations. If the part is lost and if it's not a sharp cut, try not to debride the part. Maintaining as much length is important because, as Jacob has said, you can do a skin graft after initial debridement. Anything which is necrotic and dead needs to be debrided. But try not to shorten it too much to close the anterior and the posterior skin, because then it will compromise a plan later on if the patient wants something. Then having a discussion with the patient later on, you can use a PIA flap or a groin flap. Groin flap is a good option in these cases because what it does is it brings, there's already a paucity of tissue there. So groin flap brings more tissue there. And at the same time, it doesn't compromise our plan for toe transfers later, if the patient wants a toe transfer later. To get a good hand function, we need 3 fingers. So thumb is already good, and we can get 2 index fingers as toe or 2 toes, second toes, for the ring and the little finger. Ring and little finger provide the grip for the patients, and thumb will provide the precision, and then you can use it as a pinch. If they don't like 2 transfers, at least 1 toe transfer will be helpful. That's why a small debridement, not shortening enough tissue, tagging all the important structures, so that when we're planning the toe transfer, those tagging part are important. So the same surgeon is doing the second surgery as well. And using a skin graft or a groin flap is a good option. And that's a setting where we use a lot of groin flaps if you're planning to come back and do a toe transfer at a later stage. You can also do a PIA flap as well.
Thank you. This patient presented about a week later. He had been to another center, so he didn't come in with any part.
Yeah. So we'll just treat it like it's a wound. Do not debride it too much. Whatever that is necrotic is debrided. Provide a soft tissue cover. Allow it to heal faster and quickly, so that he doesn't get stiffness and infection and further debridement. And then plan a toe transfer if he agrees for toe transfer. Some patients are not happy for toe transfer. Then you can also do, if they don't like toe transfers, you can also do a metacarpal lengthening of the little finger, like a Mattis procedure, to lengthen that, so that can act as a post. So that's why you need a flap, like a groin flap or a PA flap, to maintain the length, and then do a metacarpal lengthening of the 5th metacarpal to provide a post for the thumb. And that will be good enough for the patient. A lot of patients are very happy. But that's where the discussion is required. When the therapist, the patient, and the surgeon, the whole MDT can sit around and have a good discussion with the patient, what the patient wants. Some patients are self-employed, they don't want much. But I think thumb and one finger is important to give minimum function to the hand. And if you can give 2 fingers, that's even better.
Sarah.
Yeah, so I think certainly the good thing is the web space. That makes a huge difference for their long-term function. I think in the earlier stages, very much with this hand, is there will be a lot of swelling. There'll be a lot of thickening in the palm, and you want to work on passive movement. You want to make sure that you're really working on maintaining this arch of the hand, because even if you don't have fingers, that hypothenar, so the Ponen's digiti minimi, is able to actually bring that fifth metacarpal round into really quite an effective grip here in the palm of the hand, even without fingers. So you want to encourage the thumb into abduction, because with swelling, it's going to sit very much as it is there in an extended position and often an adducted position. So thinking of resting again in an abduction and a good wide web space. So you're working constantly and then actively bringing that thumb towards the hypothenar eminence. And I think keeping in particular the hypothenar eminence muscles nice and strong. It looks like potentially some of the insertions of the hypothenar may be okay up at the distal end. So if you've got that ability to keep the hypothenar muscles, and then a lot of functional training. So a lot of working with the patient on learning how to use that palmar grip with the thumb, using the thumb in adduction, which again is a very effective, very strong grip. So your adductor pollicis is a good, strong muscle. So keep the muscles you have strong, work on that web, and to help them to adapt their function.
Thank you. I think because of time, we'll just probably take 2 more cases.
Maybe just one, Falaki.
Okay.
There's a couple more questions for the panelists.
Okay. Okay. Maybe I should just take the last case. Yes. This is a 36-year-old right-handed dominant man who sustained multiple machete cuts to the right hand. How do you manage Anuj?
Let me just see, where are we? Because I'm looking at a different thing. Let me just open up this one.
Yeah,
I can see it, Falaki. So segmental injuries is one of the contraindications for reimplantations. Very difficult to reconstruct. It's not a bad segmental injury, but again, assessment is important. When you have a machete injury, be very careful. Like, as I said to you, trainees in the audience, it's very important that not to get carried away. Sometimes we just see it and it hits us, and then we just jump onto that hand, forgetting that if the machete has been attacked 3 times segmentally on one hand, I think that's most of the times he's trying to protect himself by putting the hand up. And that's where they get segmental injury. And there are other injuries as well. So there's no other life-threatening injuries. They're not isolated injuries. First assessment is to the vascularity. Always checking the vascularity is important. We always teach our trainees if the fingertip is you can't assess the fingertip, and if the nerve sensation is gone on both sides, sometimes they require a revas anyway. So assessment of whether it is a reimplant or a revas is very important. And if it's multiple levels, sometimes we can't even do the reimplant. So telling them about loss of finger is very important. So taking them to theater, exploration, debridement, again, fasciotomies will be required as well, and then managing them. When they have multiple fractures, very difficult to treat them. As Jacob mentioned earlier, the concerns regarding not losing the finger. Sometimes when you have a segmental injuries and it's almost like a mash of bones, in that case, you can just use a longitudinal K-bar to maintain the length and do your revas. With machetes, usually you don't need a vein graft, but if it's a segmental injury, sometimes you need a vein graft as well. more likely that you lose it. We don't see that many segmental injuries. And if you read the contraindications, one of the relative contraindications for reimplantation is a segmental level chop. Here the fingers are still attached, so I presume that we will be able to salvage it, but it'll be quite a tough job. There are different ways of approaching it.
You still have blood supply, but there is capillary refill.
Yes, so even when there is capillary refill, but if that's why assessing doing the 10 test on both sides of the fingers is very important. I always check the capillary refill, and even when the fingertip is pink. We face this problem a lot of times when patients have got good capillary refill and they have been kept for 3 or 4 days, and then when you're doing it, they have lost the sensation on both sides of the fingers. In that case, the chance of the both arteries are gone and the fingertip surviving on the dorsal blood supply is very common. And in that case, the vessels have thrombosed. So we are doing a revas at about 5 days, 6 days, and it's a slightly more difficult case, and they need a vein graft. And that's why assessment at that stage is very important, even if the capillary, so assessment of capillary refill is important, but at the same time, if you just quickly check that the sensation is not lost on both sides of the fingers, that will also warn you that this patient needs to go in the same night, if possible.
Thank you. Jacob?
Yeah, I agree with Anuj. I think here the fingers still look viable, so, but it will be necessary to stabilize the fractures. Probably I will use Kirschner wires, multiple small Kirschner wires, debride the wound, dressings and elevations to reduce edema, and then eventually think about covering the wound. Here, it appears that one will need to come back to do tendon, nerve repairs, and all that. So I'm not sure how wide the defect will eventually be. Otherwise, if it is, then a flap will be needed here rather than a skin graft to allow for secondary surgeries on tendons, nerves, and probably the bone.
Sarah?
Yeah, so I think, I mean, certainly these are, when you have fractures to this level, and particularly around the MCP joints, it's always going to be extremely hard to maintain a reasonable range of motion. I think, as you say, you may well have to go back and deal with tendons and nerves at a later stage. So probably the most important early therapy is, again, positioning. You really, that's going to depend very much on the kind of soft tissue cover that you can do, but trying to get them into as much of a sort of body position and get that wrist into extension, because there's obviously quite an injury around the wrist level as well. And the tendency is for the weight of the hand to hang the wrist. That makes function and grip in the long term much more difficult to do as well. You're going to work mostly on passive movements at this stage, presuming within the constraints of the fracture, because if you don't have a lot of tendon working at the moment, your not active movement is going to achieve less. You should be, little finger, maybe ring finger, will be able to do some active. But I think thinking about the intrinsic muscles, again, very badly damaged in that injury. So a lot of it will be positioning, passive movement, managing edema, and talking to the patient about pain management and about function. And then gradually the expectation probably is you'll end up with more of a global hand movement as opposed to very fine finger movement. So working in that posi type position for function in the earlier stages.
Thank you very much, Sarah.
Okay, thank you very much for that. Some fascinating cases, and they have generated some questions. So probably one for Anuj. Amar has asked, when doing a replant, do you repair the tendons on day one or save them for a later day?
No, we do everything in one go. So I think the full team is there. So we try to do it in one go. Sometimes it's not possible. Then we can plan a two-stage tendon reconstruction. Most of the time we do it at the same time. It's better to do it at the same time.
And Uche has asked about, in the case with all the lost fingers, rather than doing bone lengthening to create a post, could you use a composite radial forearm flap, including bone?
Yeah, you can do that. So it's all required for the reconstruction. It's the same thing as we do for thumb reconstruction. That's been described for thumb reconstruction. You can do what we call as a type D flap of Cormac and Lambati. You can do between the PT and brachioradialis insertion. You can take 1/3 of the distal radius with the radial forearm flap and do the reconstruction. But in this case will require the ulnar artery flap rather than a radial forearm, because you're going to do the reconstruction on the little finger side. So you can do that as well. It's less hairy on the ulnar side as well. A lot of units, they use the ulnar artery flap, but because the dominant artery, you don't want to use that artery as well. So so it's again all depends on how you discuss it. So you can apply the principles learned in thumb reconstruction. I think it's been described massively because thumb is 40 to 50% of hand function, but you can apply the same principles for a little finger reconstruction, because that will provide the post for these cases. But like Sarah said, if you try to teach the patient, allow the wound to heal faster and try to allow them to cup there, then it's better for them as well. Also, if I can answer briefly what Mr. Colwell has asked, highlighted about the Houston flap, and Mr. Elliott used to do a lot of these when you allow the secondary intention healing on the palmar aspect is beautiful. When you see it, to believe it. So we do a lot of reconstruction, like Macash incision for duplicants. They heal very well. So same thing for Houston advancement. It's an L-shaped incision. When you do it, when you advance it, you can leave the secondary area to heal by secondary intention. You'll be surprised how well they heal. So so they do very well with that.
Okay. And the final question, which is probably for Sarah really, is from Jibarum, who I know well from Nigeria, has asked about how can we improve the development of hand therapy in West Africa. Bernard particularly asked about short fellowships. I'm sure I can. Sarah?
I think it's, I mean, certainly I think there are some opportunities now with online teaching. I think there's, what we've discovered with COVID is how effectively you can do teaching over Zoom. Obviously if there are opportunities for therapists from here to come out to do some face-to-face teaching, that's always going to be a very good way, of managing it. There are online courses here for people to access. And I think sometimes as well, it's case discussion. I think it's useful for therapists to be able to talk to therapists in other countries and to learn by asking and talking, by understanding different cases as well. So, we are here, and I think JJ mentioned the British Association of Hand Therapists, and also the International Federation of Hand Therapists is very keen to have associate members. So if you have one hand therapist in the country who is keen to be involved, the International Society for Hand Therapists, so IFSHT, will help that person to be an associate member, will link them with other people. And at international conferences, there's then an opportunity for those associate members to be brought to an international conference as a fellowship.
Thank you. I'm conscious of time now, and we could have carried on for longer, but I think it probably is time to draw this session to a close. It's been absolutely fascinating. A little bit of housekeeping. The certificates will be sent out electronically. It's been really pleasing to see at its peak nearly 80 participants. One or two have left now, and I fully understand that. The session has been recorded and will appear with a link on the BSSH website, so please do use that resource. I'd like to offer thanks, particularly to the panelists, to BSSH Secretariat, who helped greatly with the registration process and set us up for this, but mostly to the participants who've stuck with it and generated some very useful discussion. I do sincerely hope it will have been a benefit to yourselves and your patients, and that we do continue this relationship. We're very keen to come out to Benin in early in 2021. And I think we can commit to bringing a hand therapist with the team, and would encourage you to get your hand therapist as part of that meeting. So let's continue this relationship. Have a good evening. Stay safe, everyone. Bye.
Bye. Thank you. Great to meet you.
Thank you very much. God bless.